My name is Keith Bumgardner. I'm Angie Henning's student. This presentation is called Functional Mobility Progression. It's meant to be like a review and a refresher and just a reminder to never get comfortable with what you're doing with the patient and keep doing the same stuff, to always think about that progression. I've seen therapists, not necessarily here, just on my clinical experiences, comfortable with working with a patient and they do the same thing over and over with the patient. There's never that progression. So this is just a reminder to always think about that progression. Mobilization is the responsibility of all healthcare team members. University of Kentucky here, they do a good job. I know on 8, the nurses, the techs, mobility teams, always thinking about getting patients up and moving 2 to 3 times per day. I know all floors aren't as good, but on 8, I know they do a pretty good job. And because each person is unique, on a day-to-day basis, you should always reassess the patient to see if they can progress to the next stage of that progression, and to see if they can progress to like maybe a different assistive device, just see if they can progress to more intense intervention, I should say. And there is a natural progression in movement, and this progression is inherent in the facilitation of mobility. Early mobilization, I know y'all had many people come through, and there's tons of research out there on the importance of getting people up and moving early. Just 2 articles I found. The first one showed that early mobilization can decrease many impairments of critical illness and inpatient hospital patients, and it can also decrease the length of stay with the potential to prevent or treat the neuromuscular complications of critical illness. But like I said, you put a search engine early mobilization, tons of stuff pops up. Measuring intensity, the first 2 there, the heart rate methods aren't really ideal for this setting just because so many people are on medications. These medications can alter the person's heart rate at rest and heart rate response to exercise. But the best one that I found regarding heart rate was the max heart rate equals 208 minus 0.7 times age. They say that gives a more, instead of the 220 minus the age, they say this is more accurate, and then you take the percentage of that, and they say 60 to 70% is a good range to help improve the aerobic endurance. And then the heart rate reserve method there kind of takes in the person's fitness level because it looks at their resting heart rate, and they say about 45 to 55% intensity for deconditioned individuals, which most of the people we see here are in that category. The modified Borg 10-point RPE scale and the Borg RPE scale are the best to use. Really, the 14-point RPE scale that I have shown on the right is the best, but if you want to use the Borg 10-point scale, like a 2 would be equivalent to the light category, so the 2 would be equivalent to the 11. The 4 would be equivalent to the somewhat hard. The 5 would be equivalent to the hard, 7 very hard, and of course 10 that max exertion. And this is just kind of the appropriate progression. So when you see a patient, and just say they're heavily sedated and can't do much, you can start out with that passive range of motion. The same thing we've all kind of learned in school, just progressing them from that passive range of motion to the bed exercises, bed mobility, standing transfer, standing exercises, and ambulation. The important thing to remember is to use that RPE scale to see how difficult a certain thing is. So bed mobility, getting on the edge of the bed, might be extremely hard for somebody. They give you, a 19 out of 20. Just give them an appropriate rest break on the edge of the bed before progressing them to the next category. So if they give you a 13 or above, give them an appropriate rest break before progressing them into the next stage of progression. And of course, it depends. The key assessment criteria, you always want to think about ability of the patient to provide assistance. So if they're dependent in bed mobility, you just want to think about, are you in a position to try to stand them? Or if you have help there. Sometimes, I know with me and Angie, there have been people that have been dependent, but we had tons of help in the room, so we do at least try to get them to stand so they can weight bear through their lower extremities just to get some activity lower extremity wise. But you always want to consider your safety and the patient's safety. The ability of the patient to follow instructions. You don't want to, if they have a cognitive impairment and they're not following instructions at all, you just don't want to go out and maybe walk in the halls when they're not following your commands. Never put them in a position that isn't safe. or yourself in a position that's not safe. And then special circumstances, there's always the wounds, restrictions, lines, and equipment that might prevent you from progressing a patient, and special medical orders. They might have bed rest orders, they might have weight-bearing restrictions. And that's it. There we go. The Johns Hopkins highest level of mobility scale, I just thought it would be a good thing to kind of incorporate into the UK healthcare system. It would be something that if you could document really quick. I know me going into a patient's room sometimes the nurse will tell me, oh yeah, they walked 2 times earlier. And sometimes they go in a room and I'm not sure if they walked. So this is something that's easy to fill out. Just say if a person did walk 250 feet 2 times, you could put 2 times for today, and then you can also have on that sheet of what they did yesterday. So it's always keeping all the PT, OT, techs, nurses, we could all look at this to see what a patient did on a day-to-day basis. And of course it's a 1 to 8 rating scale, 1 being lying in bed, 8 being that walk 250 feet. The Massachusetts General Hospital Functional Ambulation Classification Scale is a 1 to 6 scale that could be used. 1 being the person can only ambulate in the parallel bars and they need assistance of greater than 1 person. 2 being that the person can ambulate outside of the parallel bars, but they need assistance to support their body weight. 3 being the person only needs assistance to kind of help with balance. 4 being is they can ambulate on level surfaces, but they still need that standby assistance and verbal cues for proper gait and things of that nature. 5 would be they're independent on level surfaces, but they still need assistance or verbal cueing for stairs, incline, level surfaces. And 6 is where they can go outside and go on all surfaces, unlevel surfaces, and they're independent. Early mobility progression. If a patient is deeply sedated and unable to participate in progression, you should consider using a Valgo bed post-op day 3. I know on our floor we see a lot of patients that are sedated for 3 days and can't really do much for the 3 days after a surgery. So it's always important to use the Valgo bed because bed rest, the joints aren't stimulated, muscles aren't stimulated, you get skin breakdown, and you get motor unit loss. So the Valgo bed can be used to help prevent all of that bad stuff from happening. And it's important to talk to the team and really try to decrease the patient's sedation when appropriate because we want to get them up and moving as soon as they can. And research does support decreasing a patient's sedation after 2 days of mechanical ventilation. The sitting, standing, resistance exercises, always incorporate those into a patient's plan of care. It improves muscle strength, power, endurance, and activity tolerance. You can start off with the sitting exercises as on the top there, and then once the patient is deemed safe to do some standing and you feel safe, they're safe on their feet balance-wise, you can start incorporating more of the standing exercises. And you progress a patient if a patient can perform 15 repetitions and report an RPE less than 13. That's what most of the research says. So 15 was the magic number that I kept finding. So if they can do 15 and they report a 10, think about increasing maybe their green band to a blue band. You can also increase the number of sets you perform with the patient. So if you're doing 1 set with something, try to progress it with 2 sets and get a new RPE grade for 2 sets. This is a poll I put on a physical therapy discussion board. I put if a patient can walk blank feet using a device with contact guard assist standby and demonstrate quality ambulation, I believe it is appropriate to progress the patient to a less restrictive assisted device, thus making the therapy more skilled. And these are the results. So a lot of people think, ideally, if a patient is walking great at 200 feet with just saying using a rolling walker, you should progress them to maybe not using a device or a cane, something like that. But there's also a lot of feedback, it depends. It really does depend. It depends on the quality of ambulation. So if they have short stride length, decreased cadence, a little unsteadiness, then you can work on that before you progress them. It also depends on a patient's prior level of function. So if you're working with a 90-year-old individual and he's been walking with a rolling walker for 15 years, then of course that's probably going to be your goal. But just say if you're working with a 45-year-old guy and he was previously independent, even if he was using a rolling walker for the past year or something, a lot of the people that we see on 8, they might have been previously independent, but for the past year their heart hasn't been functioning well and they've been having to use a walker because they've been sick. So it's important to remember their pre-morbid status instead of just their status right before the hospital. And even with the standby assist, there's always stuff that you can work on. You can work on more of that unlevel surfaces, so maybe progressing somebody from a 4 on that Massachusetts scale to a 6. Take them outside, see if they can do curbs, see if they can step over objects, and just make it more difficult, because once they go home they're going to have to deal with the uneven terrain. This is just a quick progression of assisted devices. I'm going to kind of break each one of them down really quickly. The parallel bars goes to the thoracic walker, rollator, rolling walker, large base quad cane, small base quad cane, single point cane, no device. And I'll kind of talk about each one really quick. The parallel bars, they provide max stability and require least amount of coordination from patients. They're appropriate for patients who require increased use of upper extremities for assistance and increased security. I think it's a good thing of trying to utilize those parallel bars up on the 9th floor. I know it's easier said than done, getting people up there and all that, but when somebody's not able to really stand on their own and they have good upper extremity strength, it's a great place to start out, at least trying to get them to get acclimated to upright standing, to see how they feel, and then you can transition toward greater ambulatory mobility. In the parallel bars, you can work on increasing their step length, increasing weight bearing through their legs instead of their arms, and go from there. Thoracic walker or cardiac walker, this is where we start out a lot, because we have on our floor we have a lot of sternal precautions, and they're not appropriate for the parallel bars because they can't put all that weight through their arms. The thoracic walker is good because it aids post-op patients and or patients with decreased strength, postural control, balance, and activity tolerance. Any progression with the assisted devices to a least restrictive assisted device, their balance, strength, activity tolerance is going to be challenged to a higher degree. So that's the basic thought of progressing a patient. You're challenging those systems a little more as you progress them to a least restrictive assisted device. The rollator is something that we use a lot. It's nice because it has a seat. They can always park it, turn, have a seat. It's not a good device if the person is pushing down a lot with their arms, because it's not the most stable device because it has the 4 wheels, but it is the device that promotes the most normal gait pattern. And it's appropriate for patients with decreased activity tolerance because it's that seat for sitting rest break. So it's a good device for a lot of people to go home with, because they might get out in the community and require that rest break. Standard walker, rolling walker. Standard walker is good because it is more stable than the rollator and the rolling walker. They can push down more, but it's not good for the people that have cognitive impairments, because it takes that sequencing ability of picking it up, step, step, pick it up, step, step. So it's not good for everybody, but it is more stable than the rolling walker and the rollator. And the rolling walker, similar to the rollator, promotes a more natural gait pattern. And the cane, most important thing about the cane is it can support up to 25% of a person's body weight. So if you're working with a patient and they are putting tons of weight through that cane and you think it's like 50%, educate that patient to try to back down. We need to back it down to more of a rolling walker or something that's more stable. A lot of people will be hard-headed too, that's like, I always use a cane and all that, but it's not safe if they're putting more than 25% of their body weight through that cane. In summary, is just always reevaluate on a daily basis. Reevaluate a patient's balance, strength, postural control, activity tolerance, cognition, and precautions. Progress a patient to a less restrictive assisted device when appropriate. Nursing staff can always use a more restrictive assisted device, so we might be walking a patient without a rolling walker and they're very unstable, but we're working on the patient's postural control, balance, that stuff. So we can inform the nurses that, hey, when you get them up, you can use the rollator because they're more stable, they're more safe with that, and they're still working on that patient's activity tolerance and getting them up and moving. And compliance can be tough because people associate assisted device with disability, but just educate on the importance of using it, because it's going to make them safer. It can improve their vital signs. Their SATs could drop real quick without using a device, and then using a thoracic walker, they might be good to go. So just always educate the patients on why you're using a certain device and what you're planning on for the future. We'll progress to walking without it when you are deemed safe. And with this whole presentation, I was trying to find exact numbers, exact research of like, okay, this is exactly when you need to progress, but it really does depend. It really does depend, and there's not really good numbers out there of like, okay, if they can walk 250 feet, progress them. You got to think about the whole picture, look at the patient as a whole, and progress them from there. These are references.